6 hours.
Perfect. And how often are we checking the peripheral pulses?
Every hour.
15 minutes. I'm sorry, 15 minutes. I feel like everybody said the same thing.
It's every 15 minutes for the first hour, and then every 30 minutes.
15, 30 minutes. So it's 15 minutes for the first hour,
And
and then it's 30 minutes for the second hour, and then it's 1 hour after that until stable. And don't forget, we're checking for like peripheral pulses, we're checking for temperature of the leg, we're looking at the color, that kind of thing. Let's see. Are we gonna keep their hip and their leg extended, or is it okay for them to flex? Okay. And you said, how long do they stay in bed? 6 hours. Thank you. Okay, great. And we also talked about the cardiac conduction system of the heart. So, does anybody want to tell me about it? I feel like other than Kristen, everybody else decided they didn't give a fuck. So,
No, I think we all have
so tell me where we start.
Thank
Thank you. Thank you.
Left
Left and right.
And then the one with the P, right.
So now, if I give you guys a question on the conduction, right, and let's say select all that apply. And it's like SA node, AV node, bundle of his, AV fistula, and Purkinje fibers. But you guys will still pick the correct 4.
Yeah.
Of course.
Even though your bundle branches aren't there.
Right.
Yeah.
Okay. That was an argument last time? What? Why? My thing was why, right? It's a question asking you to identify what's part of the conduction system.
Right, you should know that's not.
Right. Okay, we did go over the RAS system. So I think what I really just want you guys to understand about the RAS system is that it's the regulation of blood pressure and fluid balance. That's like, yeah.
Yeah, and fluid balance.
Regulation of blood pressure and fluid balance. You guys were very impressive when we were talking about that cancer med. Do you guys remember how like the majority of you guys knew that? Yeah, that's something like that, yeah. Do you guys know what medication we give to increase the heart rate? Atropine. Atropine? Yeah, it's atropine. Atropine.
Hey, you ain't gonna be putting nothing else on here about no, taxi, right? And you're gonna have the opposite drug on here, right? Okay, I'm just making sure.
No, that's why I just wanted
It's not,
You know.
API in the question, that's what I was trying
no.
to make sure. Okay.
No, not at all.
I'll figure it
All right, so let's get into, does anybody have any questions? On the review, like on the concept, does anybody have any questions? Fair enough. Mary, you okay with the, okay. Great, did you look at the concept review? Thank you.
Yeah.
Anybody else? Going, guys. Just need eye contact to know if you guys are good. We're good. All right, sweet.
Math question, sorry, I'm still looking at the form, I'm a little slow.
I like slow, keep going.
Math question,
What do you want to know?
is that drops, are we gonna be doing a drop?
No, it is,
Factors.
no, I told you, your math questions are freebies. You have a 50 milligram tablet, your dose is 25. How much do you give the patient? Like, you have your dose is, guys, it's half a tablet, not two. What the fuck, guys?
I'm like, wait a minute, what?
You have a 50 milligram tablet.
I'm still right here for
Your
something else.
dose is 25.
I heard it the other way around, sorry.
Sorry. Well, don't worry, because the other question is that.
Oh.
So, just pay attention then.
God.
Golly.
They did 25 divided by.
Golly. How many of you guys do ECGs, EKGs at your job? EKGs. Depends on
I used to.
what your business calls it. You guys have, do you have to be NPO to get EKG?
No.
Okay. Is it best if you like use an alcohol wipe to the skin before you apply?
Yes.
Right, just because it helps it to stick. That's all. Nothing crazy. Are they allowed to talk while you're doing it?
No.
Right. Do they need any kind of analgesiac before?
No.
Should you look at the electro pads before you put them on the patient?
Yeah.
Let's talk about a patient that has hypertension and is on dialysis. Now, I think you guys don't do dialysis till next month, but I don't know, you guys are like,
We're gonna hold the med before dialysis. Is that the question?
no,
Dang it, why could it be easier?
no. When you guys have patients who are like, fluid patients, so like hemodialysis is usually categorized as like a fluid patient. Or they're in there for like fluid, just heart failure. These are all patients that are like fluid patients where we need to take fluid off of them. When we have patients like that, the first step of our vitals, every single shift, not every single day, every single shift, whether it's an 8-hour shift or a 12-hour shift, is we need to get a weight. So we're gonna start when they get admitted with a baseline weight, and so when you guys start a shift, make sure you guys get a weight for the start of your shift, right? That's gonna be imperative, because if they are on any kind of diuretic, or if they are doing dialysis, we need to know how much, if anything, they lost on your time. That's the whole reason why they're admitted. We need to show that we're actually progressing towards their discharge, okay? So I want you guys to know, when it comes to hemodialysis patients, we always want to take a weight prior to, and we always want to get their vitals prior to, right? We want to make sure that we're taking, well, there's going to be a tech that comes, or like a nurse that comes to do the hemodialysis, and they're going to be running the vitals all the time. But as us, as nurses, to hand off to that, we need our vitals and we need baseline for our shift. For patients that do have dialysis, they usually get it done through an AV fistula. Has anybody ever seen one of those?
Mm-hmm.
Okay, has anybody ever touched one of those?
Mm-hmm.
Yeah.
Okay, so you guys know that there's like a thrill and a worry, right? Okay, so you guys, before you hand off to dialysis, there's, usually they'll wrap it in like, you know, a big Popeye kind of muscle thing when they're done, but they take that off right before they start. As the nurse, you want to make sure that you can feel it, right? So you wanna know that on your shift that they got dialysis, their AV fistula still had a thriller and groovy. So like, you could hear it go like a swish sound, and then you can feel like the vibration of it. So that's also something as a nurse, because if something happens to that AV fistula during dialysis, and you didn't check it to know that it was still working, they're gonna blame you. And if you know it was working and it's documented, now it's on it. It's like a cover your ass thing, right?
You said before they go to dialysis?
So dialysis will usually come to the bedside and they'll unwrap. So when they unwrap, that's when you just want to check it. Just put a glove, you can feel it. You can keep a carrot and feel it. So that's fine. So, and the only reason why I go over that is because this ATI question itself, it's one of those trick questions, right? They're trying to throw you off with hypertension and dialysis, but really it's just your ABCs, right? But I want to address the AV fistula just in case there are people here that have never seen one, heard one, just so that you don't miss that question. But really it's just, it's your priority as a nurse. It has nothing to do. It's what you're going to do for every patient at the start of the shift, all right? Very cool. As soon as we finish this, you guys are good. 31 slides, and I think like slide 21 starts the questions. So you guys will be out of here before 9:30. So again, sorry that took so long. An email is going to be sent, but I can't give you guys back your time, right? Like that was wasted time, and that I'm irritated. My apologies that you guys had to waste your time. And I'm sorry for that. All right, let's talk about hypertension. And then if everybody wants to stay after class to chat, you can see how nicely I'm going to tell people. That they nailed us. All right, guys. Hypertension. Somebody tell me their definition of hypertension. What causes it?
Stress. Children.
Salt.
Genetics.
Nice job. Yeah, all of the above. Nice job. What race do you think is the leading contender of this?
Black.
Black is so many citizens. So, your hypertension risk factors. So the big thing with hypertension is if your blood pressure gets too high, your patient is going to stroke. If your patient ends up stroking, we now have permanent damage, right? The lack of blood flow to the brain is going to now create a disability depending on how long they're, let's say, hypoxic for. So we need to make sure that we regulate the blood pressure before it gets to that point, because even if it's a minor stroke, there's usually some type of permanent side effects, right? So that's what makes hypertension so dangerous. So on your sheet, we have underneath hypertension, we have different levels or stages. So there is a pre-hypertension, regular, there's like normal, pre-hypertension.
Stage 1, stage 2.
Yes, exactly. So, let me just see. If it is here.
Right, okay. As long as I'm not tripping. Your slides don't match ours.
Yeah.
I would say, I thought I was freaking out, but your slides don't match our slides. It's, you're on 22, right?
Yeah, those are definitely different.
Because like our third slide is chapter content.
Is what?
So go to the next one.
We don't have anything.
Yeah, so like that one for us is chapter.
8, but the bottom half we don't have. It stops at like hypertension, $3.
And you clicked, we don't have that,
22.
from,
That thing.
do you guys have 31 slides?
No, 42.
42.
You guys just increased our workload by answering that.
Can you always pretend we didn't hear
We did.
that? Yeah, no.
All right, we can just go by yours.
Oh my gosh, that's 142.
That's really weird. Oh, no.
Do you have two?
Maybe the dollar.
Okay. Well, is this a? Feeling great. Okay. Is this your third
Yeah.
slide? Okay.
We had said that.
All right. Okay.
It's so weird.
I'm trying to figure out maybe I did something or maybe I added. So many damn steps. All right, so with that, thank you guys. The things that we have to worry about with our blood pressure and how to determine is our cardiac output, our peripheral vascular resistance, and then it has to do with our blood viscosity, the volume, and then if our vessel stretches or if it is just stiff. So these are going to be your categories of blood pressure. On your test, it's going to be a pressure number, and you just have to identify what category.
These numbers on yours are way off.
Go with this slide. All right, the number with the slide, not the nurse in the meeting. Okay, hold that. This one. That one. Okay. All right, so hypertensive screening, it all depends, right? You're not, so toddlers are not gonna get them, right? It's gonna start after 3 years old. You're gonna get it at every yearly checkup that you have. The only time that you have to worry about it is when you actually become pre-hypertensive, and then that's when they're gonna start calling you back or starting to send you for like different workups. Okay. Oh, here's that slide. All right. So there's primary and secondary. Hypertension signs and symptoms. So they say that it's rare to get bloody noses and headaches. That's usually what brings people into the hospital. I had this case data and I can't explain it. I think it's dehydration. Is your blood pressure high. Or if it's not winter, it's not dry, and their nose just won't stop bleeding, it's their blood pressure. So I do not agree with Maria. So, risk factors, signs and symptoms, we're gonna talk about kidney and heart disease, their current medications, and then blood pressure readings. Everybody's familiar with orthostatic, and how ambulatory blood pressure, all that, no questions? Okay. So hypertension risk factors, we are going to be talking about our modifiable and our non-modifiable. Non-modifiable is going to be our family history, so like hereditary, age, and then race, ethnicity. Modifiable is going to be weight, their dietary patterns, so like for their diet, they either want to be on the NASH diet, the Mediterranean diet now. I don't think you're going to be able to see that in like ATI or NCLEX, but right now that's what they, like the current management, they're telling everybody to do like Mediterranean diet / DASH diet. Mediterranean diet is pretty much just like fish, meats, and veggies. They don't do a lot of fruits because it's like higher in sugar, but they cook with like olive oil, coconut oil, all this kind of healthy stuff. So needless to say, that's there. Somebody did say too much salt, so limit your salt and increase your potassium intake. Increase physical activity and check your sugar. These are all modifiable. So people with hypertension, sometimes they'll definitely be on like a diuretic. But let's say they're on a potassium sparing diuretic. If they're on a potassium sparing diuretic, do you guys have examples of high potassium?
Banana.
What?
Banana.
What else?
Is it like tomatoes or
Potatoes, yeah, tomatoes are actually really high in potassium. They'll throw your potassium off, especially in the summertime, like how people grow them, and then, yeah, the next thing you know, they're in the ED because they're having like palpitations. Their potassium level's out of control, and all they've been eating is tomatoes. Lifestyle changes, and then possibly medication. So here are our different types of meds. So our, I'm trying to think, our thiazides, ACE inhibitors, angiotensin 2s, calcium channel blockers, diuretics, and then our ACE inhibitors. Where do our ACE inhibitors come into play? In what system? Thank you. Who said it? Okay. All right, and then these are just some others. All right, so here are the complications of hypertension. Arteriosclerosis, coronary artery disease, eye damage. What ends up happening with eye damage is they get these black or white floaters, they call them, in their vision. And what is actually happening is behind the eye, they're hemorrhaging. And that's what causes those floaters, so they end up having to pretty much go get a shot behind the eye. The eye itself will reabsorb that bleed, and then the spots go away. Kidney damage, heart failure, they could end up with an MI and so hypertension urgency is when your blood pressure itself is completely out of whack. It is usually 200 over 100. And remember I was saying like people are coming into the ED because their blood pressure is sky high. So this is it, this hypertensive urgency. So severe headaches, nosebleeds, shortness of breath, severe anxiety. It doesn't necessarily mean, so for this, the blood pressure is 200 over 100 plus. But you could be, let's say, 180 over 100, and you're still going to have these. And then this is our hypertensive emergency, where it's 180 over 120 or higher. The IV nitro is what they're gonna give you. Here's your nursing diagnoses. Okay, so patient education. So we need for them to understand what they can modify. We need to find out what their lifestyle is like so that we can help them to make better decisions. And if they are on a new med, we need to talk to them about how the med is going to affect them and the changes that they need to make while on the med. A lot of hypertensive meds, alcohol is a huge side effect, and so is smoking. So we just want to make sure that they know that. Because the last thing that we need is for them to like have 2 drinks and get super drunk and not know what just happened. It creates a huge sensitivity. And then medication therapy. So this is any medication for medication therapy, especially psych meds. Even though you feel good, you still have to take it. A lot of times people feel like, yeah, but I feel fine, I don't really need it. Well, your med finally peaked, and this is why you feel so good. Don't just come off your med all of a sudden, because now your side effects and your withdrawal symptoms of these meds could be humongous, especially when it comes to these headaches. So even if you're like, oh yeah, well I feel great, I don't feel like I have high blood pressure anymore, I can't feel my heartbeat, the meds are working and need to stay on. If there is any type of side effects, we do need to know, because there's so many different medications for blood pressure, we have choices. We don't have to just settle. So what, as far as our blood pressure rate, a lot of these meds, what are they? Vaso,
Constrictors.
Yes.
You wanna lower it?
So the majority of them are kind of constrictors, right? Because we're talking about high blood pressure. When we vasoconstrict, we are kind of slowing the blood down per se. So that is going to cause an ED issue in both men and women. So for men, they're not going to be able to perform, if we call it like at a high level. And women, they are going to have a much harder time enjoying what's going on. All right, so here are our teaching, right? Hydration is super important. If they're on a diuretic, we need to make sure that they know that what they're putting in is going to come right back out, right? So we need to make sure that their electrolytes are in balance. We need to make sure that if this is a new med for them, that it could drop their blood pressure really fast, so don't fall, orthostatics, right? Does anybody have any questions on patient safety? I feel like it's like, okay. Chris, I was like, where's she going? You're ahead of me, you're ahead of me.
Mm-hmm.
All right, the nurse would indicate which of these is modifiable.
Diet, routine, weight.
Who said it? I'm gonna go 2.5. All right, national teaching to manage hypertension.
1,
1, 4,
3.
1, 4, 5.
I think it's 145.
It's 1, 4, 5.
You are contributing to the plan of care for new onset hypertension. They want information. So this is just like your nursing. So they're asking for the education, so
Isn't it number 4?
I think so, right? Health literacy, like they want to be educated. Perfect. The nurse evaluates the patient as understanding reinforcement of hypertension therapy, teaching if the patient states that hypertension must be managed for which time frame.
Lifelong.
Teaching plan for the patient to prevent falls.
Everything but 4.
Everything but 4.
1, 2, 3, 5, 1, 2, 3.
I'm gonna put the lights on. I'm sorry that it's not a slower adjustment. I'm sorry. Okay. I have to be honest with you, I'm really shocked that that chapter of all chapters is like the shortest chapter, because it seems like every patient that you guys will ever take care of is gonna be hypertensive. Where is your hypertensive paper?
Keep going by it, right there. Your index finger. Nope, go back. Oh, that one.
Okay, yeah, other than the range, other than the ranges, I think this is pretty spot on. Pretty spot on. And so here's, so pre-hypertension is 120 to let's just call it 130, 129. 80 to 89. So like it's that systolic block that is different. Stage 1 is 140 to 159. Hypertension 2 is a diastolic greater than 100. So it actually doesn't make sense according to ATI. Does anyone have their ATI book? It's alright if you guys don't. Alright. I saw one on the counter.
Mine's in the car.
If nobody has any questions or needs me, you guys are free to go. It is way off from this paper, from this ATI book, so I will do my research and get back to you guys with the correct numbers. In the meantime, though, we'll go over the slide. With what's in your slide, okay? Does anybody have any questions?
No.
Did you guys want to start chapter 3?
Oh, shoot.
You guys are all achievers, no?
We have to get home to study and prepare so we can be prepared for tomorrow.
Bravo.
That's how much we overachieve.
Adios.
I like to figure out how I should put back because I'm not. Especially for the size of the house.
But it told us about like pre-hypertension and the different stages and it gives you figures tonight and send you a picture.
I have it here. Oh, okay. Right, but it's like 2022, and this is different from here.
Well, and what's on this slide is coming from 2018
Oh my God.
and this is 2021.
Right. So I need to get it as from 2025.